Hey YouTube, I'm your fave Nurse B. Today we're going to talk about talking to doctors. Now I know this is a subject that a lot of nurses they hate doing it, especially new nurses. I've heard even some seasoned nurses, they just say they hate talking to doctors. For one, I don't have an issue talking to doctors. I mean, they people, so they're people just like me and you. But there's certain things you need to do that are going to help you to have the best conversations with doctors and to get what you need for your patients as best as possible. So let's get right into the video. So first thing first, let's talk about scenarios where you would have to actually talk to a doctor. So if you're getting orders for them, say they're just calling you and saying, hey, I want to change such and such pill from this to this. So you would do that. Or it could be a situation where a doctor is in your facility or at the hospital, whatever, and they're going to give you direct orders, or they're going to write out orders or type out orders or whatever, or they're going to ask you, how has such and such been? They're going to be instances where something's going to happen to a patient, whether they have a change in condition or they're asking for a certain, the family's coming to you saying, hey, can you see if her doctor can give her therapy orders because I think that she needs help, standing, blah, blah, blah. You have to then call the doctor and try to get those orders from the doctor. So that's that. Another thing to think about, that first call to the doctor or any general as a new nurse, you might not even talk to the doctor. If it's during the day, more than likely you're going to call the doctor's office and you're going to be talking to their secretary. Or their nurse practitioner, something like that. You will tell them what you need, and then some doctors, they say, they approve for the nurse practitioners to give out orders on their behalf, or they might say something like, oh, well, I'll forward this to the doctor and he or she will get back to you, blah, blah, blah. But just know that during the day, you might not even have to talk to a doctor. But if and when you do, this is what you have to think about. So first thing first, say for instance, let's just go through a scenario. Let me think. Say for instance, your CNA comes to you and say, Mary, she's in there breathing really heavy and she's like wheezing. I don't know what's going on with her. Okay. At that point in time, you get off your butt, get all your stuff for vital signs, and you go in there and check Mary. You check out her vitals, listen to her lungs, ask her questions if you can, how do you feel? When did this start? Ask the CNA, when did this start? Did this only start when you moved her from the bed to the chair, or when she got up or whatever and started walking? That's when she started having these issues. How long has this been going on? Has this happened before? You need to do a thorough assessment of your patient. First things first. Keep in mind that this MD is not there. They are not there to see the patient. You are their eyes and ears. You are essentially them looking at the patient. And you have to give them the information as thorough as possible. That's why assessment is key to nursing. You have to assess your patients. So you get all this information. Maybe you look at her meds and see, okay, you know what? I checked her oxygen level was at 89. All right, let me go ahead and put her on some oxygen. She has an order. She can get 2 liters of oxygen. Let me put that on her and see if that helps. You put it on Mary. Her oxygen goes up to 92. Great. But she's still wheezing. You still hear this wheezing. You listen to her lungs. Her lungs, they're diminishing the bass. It's like you can't really hear that much air going through in the base of her lungs. Okay, at this point, if you're a new nurse, you might not know what's going on. But if you're a seasoned nurse or you've just been a nurse for a little bit, you might think, oh, well, maybe she's got, pneumonia. It could be that. It could be bronchitis. It could be a number of things. You check her, like I said, check her lungs, do all that, do your assessment. That's your assessment. Her O2 was low. You put her on oxygen, they brought it up. But her lungs are still diminished and you're still hearing wheezing. Okay, you look and she's still kind of like breathing, kind of labored. Okay, well, let me see if she has a breathing treatment she can get. Let me look at her meds. She has an order for a breathing treatment. Boom, throw a breathing treatment on her. Tell the aide, and tell the resident. Talk to your residents. Tell them, hey, you're looking a little bit better, but I'm not really hearing a lot in your lungs. I'm going to call the doctor and let the doctor know what's going on. Good. That relaxes the patient. That lets your CNA know that what you're about to do. And then also this helps the CNA to be more like okay, let me check on this patient more and more and let the nurse know if there's any changes going on. So that's that. You did your assessment, you communicated with your patient, communicated with your aide, on to the next one. So after you do that assessment, you're looking at her meds, seeing what she has. Maybe you're talking to the CMTs. If the CNA doesn't know anything, maybe you talk to the CMT and say, have you seen, were you here yesterday? Was she like this at all yesterday? Talk to the aides that were on the floor. Ask them, hey, did you work yesterday? Was Mary acting like this, or was she having any issues? Go from there. Now at this juncture, you can either call the family first or call the doctor first. I, for one, like to call the doctor, tell them what's going on, get the orders, then call the family. Because when I call my families, I like to be able to tell them a problem, tell them what we're going to do, and then tell them that we're going to follow up with them as to if, you know, this is going to work or not. But depending on the doctor and depending on the family, you might need to go to that family first. It just all depends on your patient and on your doctors. So with that being said, the next tip is you need to know your doctors. If you're a new nurse or if you're new in that facility, whatever the case may be, you might not know anybody. So I would then ask first, hey, how is Dr. such and such? How do they, you're like, how are they? Just ask another nurse. Other nurse might be like, oh, she's fine. You know, she, whatever you want, more than likely she'll go ahead and give you the order for. Or she might say, oh, she, man, that doctor, I don't know, you have to, it takes forever to get in touch with them. Or they might say, oh, that doctor, you know, they're really good, just make sure you come to them correct. And with that being said, that's why I say do your assessment. So get an idea of your doctor. Some doctors, they are more, they waver more towards what they think the family might need. Maybe they've been with this patient for decades and they trust the family. The family knows, you know, certain habits and certain trends that happen with this patient over time. Say for instance, every time during this year, this person seems to always get pneumonia or bronchitis or whatever. The family might know that, so the doctor be like, okay, we're just gonna do what we did last time, blah blah blah. Or the family might be extremely like gung-ho about certain things, like, I don't want mom to have this, I don't want her to have this, da 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 da. The doctor's like, see what the family wants to do. If they want to send her to the hospital, send her. If not, you know, we're going to do this. So sometimes you have to call the family first or call the doctor first. It just depends. Again, if they're on hospice, there's other things that you have to think about as well. But I, for one, like to call the doctor because I want to first and get everything that I need from that doctor and then call the family. So that you tell them, this is the bad thing, but we're doing this right now. He or she is stable. And then once I hear anything, I'll get back with you, or I'm leaving off my shift in another hour, but I will report to the next nurse about what's going on and they will get in touch with you. Boom. That families love that. So let's move on. So first thing first, do your thorough assessment. Thorough. Do not call these doctors if you haven't looked at the meds. Don't call the doctors if you haven't talked to the patients, if you haven't talked to your CNAs, if you haven't done vital signs, if you haven't looked at nurses' notes to see if this is something that's been going on for a while. If you haven't even seen the patient, don't call the doctor. Some people, yeah, anywho, do a thorough assessment. And then secondly, know your doctors. So third, you can use an S-bar. So S-bar is a way of communicating with doctors. It's like this sheet of different things that you fill out, and it's like, what's the chief complaint? What are the vital signs? What are the things that makes the condition worse or better? What have we done in the past? What body system is being affected? Blah 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 blah. Have there been any recent labs? That's part of your assessment too. Look and see if we've done some labs in the past few days. Look and see if the doctor was in yesterday and he or she said this is something that they're aware of. They're just monitoring. Blah blah blah. You have to kind of investigate things. So you can use the S-board as a way to talk to the doctor. And I will post an S-bar in my Facebook group. So if you all don't know, I'm starting a Facebook group for you all. It's going to be called Your Favorite Nurse B. I do not have another name for it. But it's basically just for all you CNAs, CMTs, nurses, people in nursing school, people who want to go into nursing, interested, whatever the case may be, or people that just like to watch my videos, and you all can go in there. We can have a little community. We can all communicate, and it just be, you know, a good way for people to talk to each other and to talk to me, and we be able to communicate more often. So I'm going to put an S-bar, a picture of one, in that group for you all to see, the one that I use in my job. So that's that. So yes, SBARs are really good for new nurses because it outlines everything. All the information you need that really fits your assessment is on there, and you just kind of read through it. Such and such and such and such. You just say Mary, I don't know what I said her name was, Marie Calendar. Marie Calendar. So we had a patient, Marie Calendar. She was having shortness of breath and wheezing. I checked her lungs. She did have some diminished lung sounds in her basis. I gave her O2 because her O2 was only at 89. Brought that up. It brought her O2 up to 92. Right now she is comfortable, but she's still having some shortness of breath. She's on a breathing treatment right now. And I noticed that you did an x-ray, a chest x-ray about 2 weeks ago, and it was negative. Did you want to follow up on that? Ask for what you want. Now, you might not know what you want. You might not know. But doctors are busy. They're busy people. They got tons of patients. Help them out a little bit. Be like, hey, you did this. Do you want to follow up with a chest x-ray? 2 weeks ago it was clear, but this week she might have something going on. You want to check that? The doctor be like, oh yeah, that's a good idea. And some doctors would be like, that's a good idea. Do that. Also, can you check her CBC and BMP tomorrow morning? I want you to get her on scheduled duo nabs, breathing treatments, and make sure you keep her oxygen over 91 or over 92, and push fluids, and make that chest x-ray stat. Call me back tonight. Boom, you got what you wanted. You said what you had to say. Bow. Not always that easy. The situation is not always that clear and cut dry, but that's just what you have to do. Think about doctors. They're just people. They're professionals. They got to where they are by going to school, by being diligent, just like you. So don't get bombarded by, oh my God, it's a doctor, I'm afraid to talk to them. Just come correct. Come with the right information. Look at your patients and then tell them what you want and go from there. If you don't know what you want, just say, you know, what it is that you would like to do. It's not hard. So I hope that helped you all as far as being able to talk to doctors. The biggest thing is just knowing that you are that doctor's eyes and ears. We have a doctor at my facility that I work in. Some people are like, oh, I can't stand him, he's too hard, da da da. But he has really made me to be a stronger nurse, because it's been times, especially when I was a new nurse, he was like, well, I'm not there, I need you to tell me what's going on, you know. And I'm like, okay. And I never thought about it like, it's true, he's not here. And then I remember one time earlier this week, before I went on maternity leave, I had saw that he had faxed somebody something, and he had replied. He was like, I'm not sure what meds she's on. You need to send me a med list. I have 1,200 patients. I'm sorry, I cannot remember everyone's meds. And I was like, ooh, when I saw that 1,200 patients, I was like, sheesh. But it's true. When communicating with a doctor is not just over the phone. You have to think about faxing too. When you fax a doctor, first things first, think about HIPAA and make sure you use a cover sheet without any type of identifying information on it. You need to do that and fax it to the right doctor. Because I think, like, technically if you fax it to the wrong doctor, like, that's still a violation of HIPAA. Even if you made a mistake, still violating HIPAA. But anywho, cover sheet and then put all your information. So say for instance you didn't talk to the doctor about this, you called, you faxed it in. FYI, if your patient has a change in condition, like with Marie Calendar, you need to call the doctor. You need to. That's not something you can fax, because this person is clearly in some type of distress and you need orders and you need to get on it as soon as possible. But say for instance a patient family comes to you, or not even family, say you yourself, you're feeding you're in the dining room looking at all your patients, and you see that Jack Daniels is over there. Why am I random people? Anywho, you see that Jack Daniels is over there, and he, for some reason, he's trying to feed himself, but it's just getting harder and harder for him. So you say, you know what, let me see if this let me do my assessment. Ask the aide, has he been doing this for a while? Have y'all noticed that he's not been able to feed himself, having issues? Oh yeah, it's been like that for like a few weeks. So that means nobody else did anything. So it's up to you as a nurse to be like, you know what, let me see if I can get some orders for them to get maybe occupational therapy to look at him, and maybe there's different spoons or forks or any type of silverware this person can use to help them to be able to feed themselves better like they used to. Look through your chart, make sure somebody may have already talked to the doctor about it. So look through your nurse's notes and see if anybody said anything about it. Talk to people, just get an idea of where the situation is at. And then if you see that nothing is going on, fax the doctor and be like, hey, I wanted to get an order for, not hey, but such a patient is having increased difficulty feeding self. Maybe have an order for OT to evaluate and treat. That's all you gotta do. Boom. That's something you can fax, because him not being able to feed himself is not life or death, because you can feed him or your CNA can feed him. But if it's a change in condition meaning this could go left or right for this patient, it can go from really decent to really bad for the patient, call the doctor. You have to cover yourself. Call the doctor. Even if it's something that you think is a big deal and you call the doctor, they're like, okay, thanks for letting me know. Chart it. You chart your full assessment, what's going on with the patient. You call the MD. MD gave new orders. Family notified. And that's all she wrote. And also, number one thing is be respectful. Now, this should go without saying, but some nurses, some people are not respectful. They talk to people however they want to. I, for one, I'm very respectful with MDs. I think that they worked hard for their position. You know, they should be respected. I think anybody really should be respected. But anywho, be respectful for them. It's some doctors that are just flat out rude. They're going to talk to you any type of way. They don't care. But at the end of the day, remain professional. Get your money and go home. It is what it is. Cover your butt, chart on what they say, and go from there. If you have any other specific questions, like different scenarios that may have happened, or just specific questions you have about nursing or communicating with doctors or whatever the case may be, let me know. And also check out my Facebook group, Your Faith Nurse B. And yeah, that's that. Thanks for watching. Peace. Something that you need to do when you're talking to a doctor and giving an assessment, be specific. So when you say that a patient is they have anxiety. Anxiety can come in many different shapes and forms. Anxiety can be the patient is withdrawn, the patient is having issues with their breathing, that can be seen as anxiety. The patient is constantly asking the same questions over and over again. Patient is telling you, I feel anxious. There's a lot of different things. So when you talk to the doctor and you say kind of like filler words, like not filler words, but like broad words like aggressive, agitative, restless, things like that, you need to be specific. And I had a doctor tell me, be specific, I'm not there. So when you, instead of saying restless, you can say patient is, fidgeting in their chair, they're trying to get up, and they have repetitive questionings, so, or repetitive verbalizations, things like that. That lets your doctor know, okay, this could be a number of things. Okay, this person's on this med, maybe I need to decrease it, or maybe I need to increase it, or maybe we need to do this. It helps to paint a deeper picture of what's going on with the patient versus you just saying she's anxious, or versus you just saying she's lethargic. Say specifically what's going on. It's hard to arouse the patient. You could say that. You could say that the patient is, when I'm talking to her eyes keep closed, and I had to constantly touch her or move her to get her to kind of arouse her, to get her to start talking to me again. Patient has slurred speech, things like that. Don't just say the patient's lethargic. Like, you need to go into detail when you talk to people, when you talk to doctors. And yeah, that's that. So doctors they know. You might not think it. I'm gonna tell you this. You might not think it, but doctors, they watch you. They watch certain nurses. They know who's doing work. They know who's not. I had a doctor who, I didn't even think he was paying attention to me. I'm a float nurse. And he was like, oh, you're over here today. And I'm like, yeah. And he was like, oh, you're usually on the rehab floor. Da, 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 da. I said, yeah, I just go wherever I need to go. I'm a float nurse. He said, and as he was walking off, he said, well, you're pretty good. He said, no, what did he say? He said, well, you're good. I like you over there. That's where you should be. And then he like kept walking, something like that, he said. And I was just like, oh, I didn't even notice that he knew who the heck I was. So they watch you. And I've had doctors complain about nurses and say that, you know, some nurses have been at the nurses station on their phones. Nurses or, you know, talking, cursing, things like that. When a doctor come, guess what I do? I tidy up my station, get up, and keep on pushing. Most times, though, I will sit there and talk to the doctors or whatever. If I need an order or something like that, I'll talk to them. But I just let them get their space. They're going to take your seat anyway. As soon as you get up, honey, they're going to take your seat. So don't even try to keep it. But that's that. If you're talking to a doctor in person, though, say, for instance, they're coming in to see somebody and they write orders. I still work at a facility with no computer, so I had to look at those orders and try to decipher them. So what I think is the best thing to do is while they're there and they write those orders and put them up for you, look at them real quick and say, okay, cool. If there's something on there that you don't understand, ask them right away, right then and there. Don't be scared and just say, hey, I want to clarify. Did you want to do this for da-da-da-da days or this days? Did you want to, since we're starting this, do you want to stop this? It's okay. They can either say yes, no, look at you crazy, whatever. You're doing this for your patients. You're doing this for your job. You don't worry about how you might feel at that instance or embarrassed or, you know, shy to talk to the doctor. Don't think about that. Think about what you're there to do. Take care of your patient and get your check. So talk to them. I mean, they're people just like you. Or say they're not even to see your patient. You say, excuse me, doctor such and such. I just want to let you know that so let's see, Marie Calendar. I just want to let you know that Marie, she's been refusing her medication. She refused it for day shift, and they're saying right now they were trying to give it to her. She's not taking it. I'm not sure why she's not taking it. Da 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 da. Boom. Or you can say, hey, doc, I just want to let you, not doc, but excuse me, doctor, I just wanted to let you know that, you know, our patient blah 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 just had emesis ×2. Her vital signs are stable. She had a BM today, it was large, but she's still saying that she's having some upset stomach. Boom. That's that. They're there. That's like your golden ticket. It's nerve-wracking to have doctors around you and they're asking you questions, but that's like the golden ticket. They're there, they can see the patient, they can do their own assessment, and you're good. I mean, of course you need to kind of investigate and do some things, but they're there. You don't have to create this image for them. They are there. So take advantage of that. When you talk to doctors over the phone, you get phone orders. They teach you this in school, but make sure that you're doing it in real life because it will save you. When the doctor gives you an order, repeat that order to them. You might find that you messed up some things, or you might find that they messed up something. So they give you this long order. You say, okay, we're going to do da 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 da. And the doctor's like, no, I want 500 milligrams. You say, okay, you want 500 milligrams of Levaquin Q12 da 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 hours for the next 7 days. Okay, can you give me the diagnosis for the antibiotic? At my job, at least, anytime I get an antibiotic, I need to have a diagnosis, because when you get when you are putting a patient on an antibiotic, you need to know why you're treating them. Excuse me. If you don't know what you're treating them for, you don't know if it's working. So how are you going to be able to give effective care? So you ask them, you know, can I get the diagnosis for that? Especially if they're giving you an order for antibiotics without any type of clinical showings of why the antibiotic is needed. So they didn't do a UA or check their urine for a UCI. They didn't do a chest x-ray. They didn't do a wound culture. They didn't do anything. And you're like, okay, so why are we doing antibiotic? Ask them. You have to be assertive. You know, don't be timid. Be assertive, but be respectful. Come correct. Advocate for your patients. Some doctors would be like, nope, I don't want to do that. You'd be like, okay, go further into your assessment and say this and this and this is going on. She's saying she's in a lot of pain. She says she gets this pain, you know, throughout the night most of the time, and it wakes her up out of her sleep, blah 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 blah. and she's up during the night and she sleeps all day. That paints a picture. Now the doctor's like, dang, okay, if she's sleeping all day, she's not eating. If she's up all night, then she's in some type of anxiety, something's going on with her. So we do need to look at her meds and change some things. Advocate for your patients and just be assertive. But the most important thing that you have to do is know that you went to school for a reason. You have your degree, your certificate, whatever, your license, for a reason. You are competent and you are a healthcare professional just like any MD that comes your way, okay? So don't get discouraged. Don't be nervous. It comes with time. Over time, you will get more comfortable talking to doctors and know how they are and who they are as people. But just know that you got it. You got the knowledge. Just use it, and yeah, you're going to be successful. Okay, you all. Peace.